to say it again. Sorry, I was muted.
Vivian? And Councillor for Dewsbury South.
Yes, Councillor Bill Armour, Kirkburton Ward.
No, sorry, I'm just trying to get the volume up in the headphones. It wasn't to speak. Apologies. Oh, sorry. Oh, gosh. I couldn't hear. There's a problem. Sorry, I'm Leslie Warner, Councillor for Colne Valley, and I'm also a governor for the Huddersfield NHS Trust Foundation Trust Governors, those people. Oh, God. Should I go back to bed?
Hi, I'm Helen Clay. I'm a voluntary co-optee on the panel.
Hello, I'm Kim Taylor. I'm a voluntary co-optee on the panel as well.
Jo Lawson, Councillor for Costamore and Neverton Ward.
Alison and Vivian, would you like to introduce yourself? Alison first.
Okay, thank you. Hello, I'm Alison Munro. I represent the residents in Almonbury Ward on Kirklees Council.
Thank you, Jackie. Councillor Vivian Lees-Hamilton, Murfield Walk Councillor and panel member, and apologies. The computer will not turn on the camera, so I either have to leave the meeting and rejoin or go without the camera.
Okay, all right, Vivian. If it's your choice, but we're happy if you don't want to put the camera on. If you're not able to put the camera on, that's fine.
Okay, I'll stay with the meeting, Jackie, just in case I lose the connection completely.
Okay. Stacey, do you want to introduce yourself, and then we'll leave it at that?
Hi everybody, Stacey Appleyard. I'm the Director of Health Watch Kirklees.
Right, thank you very much. Can we do minutes of the last meeting, please? First of all, do we believe that they're a correct record?
Yes, I was just hoping to bring attention to one part of the minutes on page 9, I believe it is, where we discussed domiciliary care spot contracts with the council, and I was hoping that we get a response from the council on that.
So that was from Amanda, wasn't it? So Richard, could we pick that up then, please? Yeah. Okay, we'll pick that up. The other thing on page 9 is that the confirmation, we have had information from around in-house and outsourced activity that has been provided. Has that been shared with members of the panel? Yeah. Okay. Sorry, has anybody got any interest? Leslie, we accept that you've already declared yours. Anybody else got any interest that they'd like to declare?
Nothing to declare, thank you.
Okay, lovely. Deputations, petitions?
None.
Questions from the public?
None.
we're a meeting in public anyway, so right, I think we're on to our new plan for adult social care reform. Because we got the presentation yesterday, not everybody's been able to read right through it, so you can have a little bit longer. So when I say a little bit longer, we normally give 10 minutes, so maybe about 15, 20, to just make sure that everybody's got it.
Thank you.
Oh, please will you introduce yourself and anybody else that's going to speak on behalf of the presentation?
Yes, just here with Richard Parry, Strategic Director for Adults and Health.
So I'll just, whilst Lexi is getting ready with the slides, just remind people that we were working to an implementation date of October 2023. You'll have seen nationally there's a pause till October 2025. But nonetheless, we felt it was helpful to brief the panel on the breadth of social care reform, because there are some elements that will continue going forward, and there are some where, as a local government sector, there's been an ask for a 1-year deferment to allow a proper 2-year lead-in period, and so there'll be a number of things we'll need to be on with next year anyway.
Thank you. So I'll make a start. Set against the context of a wider programme of change, look at some high-level demand, and then a little bit about CQC assurance framework, which will be coming in from next year, and then a bit of a summary of our key work and next steps. So social care reform was built on existing social care legislation, so the Care Act, and also some policy intent that was split between 2 white papers, and it places a greater emphasis on personalisation, housing, technology, advice and information, and carers, none of which are new areas of work, but it did just provide a little bit of additional focus on those areas. I'll touch on CQC, gaining inspection responsibility, a little later, but that will be in the same way that Ofsted currently comes in to assess children's services. There's significant reform in the way that people pay for their, or in the way that they will pay for their social care, and there are concerns around the capacity needed to address all this when it's set against ever increasing demand, the recent changes in the NHS arrangements, which have required social care involvement, and of course the sort of day-to-day operational pressures. So the Health and Care Bill received royal assent on the 28th of April this year, and the primary aim of the charging reform is to redistribute the financial responsibility for paying for an individual's care. So at its simplest, it means, or it would mean, that the cost of the individual would reduce and the cost of the local authority would increase. And that's around the introduction of a care cap, so introducing a maximum amount that anybody would be expected to pay for their care over the course of the lifetime, and also the opportunity for more self-funders to come to the local authority to ask them to arrange for their care. So, as Richard mentioned, the charging elements of reform have been deferred until October 2025, but the lead-in period means that we're still going to be continuing with that preparation work. And the CQC aspect of it is not deferred, so that is still definitely coming in from next year. I won't go through this in great detail, but I just thought it was a useful slide to bring up, just to show that the charging element is just one aspect of a much wider programme of change. So we've got the recovery stage, which is around sort of post-pandemic, coming out of the workforce recovery, NHS recovery, and the assessment backlog recovery, which would then lead into the reform period that we're in now, which includes things like the assurance, liberty protection, safeguarding coming in next year, and then ultimately lead into to transform into new models of care with those enablers, so around systems and technology and looking at workforce development. But I think it's fair to say that actually we're still very much in that recovery stage. So even though we're moving through into the reform elements, there's still, kind of issues around the workforce and and backlog. So it's balancing all that against the new legislation as well. I've included this in the slide pack. It is very generic modelling. It's based on model growth and population estimates up to 2032. So it's quite difficult to see on the screen. But if you sort of look at the purple line and the dark blue line, that's where we would see a kind of usual trajectory of demand. And then you can see the light blue line and the green line is the implications that reform may have on the demand. So you can see that it goes up quite significantly. So irrespective of whether it comes in 2025 or not, that's what it's looking like at the moment if it was to go up and reform was to hit in 25. So our approach to reform is that we immediately put together a social care reform oversight group, taking very much a cross-council approach, so linking in with other council services, legal, finance, HR, etc. And the social care reform oversight group has got a number of work streams sat beneath that are focused on particular elements of work. So one is on CQC inspection, the other might be on policy and pathways, another on data and intelligence. We've got a lot of support from Yorkshire and Humber and peer support through ADAS. And I think the important thing is that even though we've, publicly in the autumn statement, they've delayed the date, the work that we need to do, we still need to do it because actually it still offers opportunities for efficiencies, better use of digital solutions, that type of thing. So we were, if the reform had have come in April next year, we would have had to have a platform where people who use services and their carers and families would be able to do an online Care Act assessment to help with some of that demand. That's something that we're fully continuing to do. It's the right thing to do. It'll give people more options. It's more flexible. People can do those assessments in their own time. And if you think at the moment that 90% of our financial assessments are done digitally, then that's given us an opportunity to really maximise efficiencies. So certain things, just because it's been paused, we are absolutely carrying on with because it's the right thing to do. We're also looking to commission some external support to do some more specific modelling, but not just around charging, but demographic demand generally. And again, more opportunities around efficiencies and savings. If we're thinking about that, promoting independence, the early intervention, keeping people as independently as for longer as they possibly can. So again, I won't go through this line by line because I'm conscious of time, but the assurance framework is still actually considered draft, but I think I don't anticipate that it will change hugely. But the real driver behind it was, I think, throughout the pandemic, the data and the intelligence that the Department of Health were able to get from adult social care nationally wasn't as strong, or there were more gaps in comparison to NHS data. So that was a real driver to try and get that level of consistency, and also so that local authorities can accurately benchmark themselves against national, regional and other local authorities. So there will be a duty for CQC to assessors. That will be coming in from April next year. The Secretary of State will be able to intervene if improvements are identified. And if that is the case, then they've said that there will be funding to support those improvements, but we're not entirely sure what that looks like. They've not really given a great detail about that. So they've worked very closely, the Department of Health have worked very closely with sector leaders, so the Local Government Association, ADAS, to co-design a local authority assessment. And I think the real important one there is around being informed by what matters to people who draw on care and support. So I think it's really putting people at the heart of it. They're trying not to make it overly onerous, but obviously the outcome of all this will be to kind of assess how well we're doing and where there might be areas that we need to develop. So the framework is broadly split into 5 areas. So the 5 key questions at the top are based on what are known as the I statements, and that's based on what people expect to need as a basis for gathering feedback. The second one down, the quality statements, are very similar to the I statements, but they're we statements, so they would be the ones that the local authority set. And then the third pillar is the experiences of people, so people who use services, carers, families, staff, partners. And then the fourth one is around data and information, which obviously there'll be a framework around that, which actually came out last week. So again, I won't go through all these, but the voice of lived experience is definitely coming through very strongly in their approach, and the need for that consistency and flexibility across the adult social care. So the scope of CQC is in 4 domains. So the first one is around working with people, so that'll be picking up things like assessments, reviews, supporting people to live healthier lives. So again, that's the link with the communities side of things, with community-based interventions, early intervention. Theme 2 is more around providing support, so that's more focused on the care market, provision, integration, partnerships, and again, the community support that we've got. The third one is around safety, so systems, that'll be looking at pathways, transitions, and the role and functioning of the Adult Safeguarding Board. And then the last one is around leadership and workforce, so that'll pick up the governance, transformation, all those types of things. So in terms of where we're up to and next steps, we did submit the fair cost of care exercise to the Department of Health on the 14th of October, which was a requirement of the reform at the time. We were supposed to be getting feedback from that during December, but we're not entirely sure what's happening with that, but it will need to inform the market position statement. But central government haven't got back to anybody around that yet, so we don't know whether the timescales have shifted, but I suspect they probably have a little bit. The local account we will be publishing this year, so that's our account of where we are able to tell the public what we've been doing over the last 12 months. You know, what areas that we think that we've done well at, and areas that we think actually we recognise that there's still a little bit of work to do around this. So that will be a public-facing document, and there's a working group through ADAS, so we're all working to similar timescales on that. I mentioned about the digital options and exploring that a lot further, so we will be going ahead hopefully with the online Care Act assessments. And then, as I said, the external support, there's a procurement exercise that we're just at the early stages of, to look at doing quite an in-depth diagnostic that will help us to manage volume demand and understand that volume demand as it changes in the future. And then, in and amongst everything, there's always the consideration around the impact on inclusion and equality. So at the start of the reform, the government did do their own impact assessments, but obviously we'll need to make sure that we're doing our own assessments for any aspect of this, including CQC. So I think I wanted to just put the focus on more on the CQC, because that is the bit that's in view for next year, but just give you a little bit of an idea about the reform and the implications of the delay, because actually for us it will still very much be business as usual, and in getting, you know, so that we're in the best possible position that we can be if that does come in 2025. So thank you very much, and happy to take any questions.
All right, Alexia, thank you. Richard, is there anything that you want to add at this stage? Okay, we'll go straight to questions from the panel then, if that's all right. Is anybody? Helen?
Because we've had a whistle-stop tour of that, and it's the first time I've seen it, so I just wondered if you... Sorry, I'm looking at it. So I just wondered if you could possibly take me through, if as a user of these services, what difference would I see from assessment to delivery and after? What would it mean for me as a person in the community?
So do you mean in terms of the reform aspects of it, or the sort of digital things?
So the things you've gone through, what would it mean for a person?
Yeah, I think, yeah.
So I wonder if I might just start. There's, when people have talked, successive governments of all political types have talked about needing to sort out social care. And broadly, you could describe that as being one of 3 spaces. The King's Fund had talked about 12 different variations of this. But solution 1 is that local authorities feel that they have sufficient funding to invest long-term, not just in the very pointy end of social care delivery, so care packages, but ensuring that there's kind of a breadth of opportunities to promote people's health and well-being if they have a disability or kind of in older life. And to be able to pay providers a kind of fee that reflects the value of frontline social care delivery. I think providers would say that sorting out social care means that actually they have a fee rate that allows them to invest in the long term of their business, so that if they're running a care home, it's a good quality establishment, and that they can pay their staff a rate that reflects the value of social care. And the third sort of sorting out of social care is if you're paying for your own care, then social care reform would look like a change in that, so that actually social care was closer to NHS care, so free at the point of delivery, and that you had some certainty about whether or not you're going to have to indeed pay for the cost of your care, and clearly it's means tested, but everybody makes a contribution to the cost of their care. And social care reforms was predominantly focused on that latter bit, so changing the relationship between individuals paying for their own care and moving more of that towards the state paying towards people's care. And so social care reform wasn't really focused on those other bits about, you know, either kind of social care workforce or the kind of what the social care offer was. I think as Lexi was saying, in order to accommodate helping people who previously been paying for their own care to move across to be supported by the council, we anticipated we'd put in place have a number of digital offers that helped people navigate the system better. We brought, I think, to a previous version of this scrutiny panel, the adult social care vision, or the council's vision for adult social care, which talked about the much broader set of aspirations that as an authority we have around good social care. So about co-production, about people managing their own care well, about greater use of digital solutions, about assistive technology, about really good housing solutions, be that kind of an adaptations, be that things like extra care housing, supported living arrangements we've got. And so social care reform really was predominantly less, I think, about what the social care offer looked like, and much more about who was going to pay for their care and how that was going to be paid. And it might be helpful if perhaps we brought back at some point that kind of social care vision and talked about that kind of broader social care offer that's the ambition of this council and where we are in terms of delivering that. And the local account that Alexi referenced is very much our statement back to people about these are the things you told us previously were important, and this is how far down the line we are with those.
So, if I understand you correctly, are you saying that as a person who's looking to receive these services, that the only thing they would notice differently would be how it was paid for? So there's no difference so we would continue with the digital assessment. That's what we're doing, and how it was paid and how the services are paid for would be different.
So I think the original thrust of much of that social care reform in the context of this presentation was from October 2023, so from next year, making two changes really. One was the amount of money, to national reform. One is the change to the amount of money that people could retain before they paid the full cost of their care. And secondly, for people living in a care home, in residential care, removing some of the cross-subsidy where people who pay for the full cost of their care pay a different rate to that which people funded by the council pay. And so that was the thrust of the reform, was predominantly about just charging reform. And that's obviously pushed back to 2025. There's a whole set of other changes that we are working on, which are about how we have a better offer for people, but we're kind of outside of that national social care reform. And so we haven't really covered those in this presentation purposely, because we just wanted to focus on that kind of national charging reform. But happy to kind of talk as a different panel meeting about that much broader range of things we're doing to improve the social care offer for people.
Okay, thank you for that offer, Richard. I think we might take you up on it. Have we got other questions from panel members? Leslie?
Yeah, hi. Well, it will be no surprise if I tell you that I am completely and utterly disillusioned and angry for all of you because the way social care keeps being putting back into the long grass, I know we can't raise the issue of governments and so on, but what is clear is it's been put back till after the next election. And we've had so many stories about how things are going to be funded. And the idea that the local authority is going to be in a position to help funding from next year when the state of, I don't know, the latest figure is 60-odd councils going bust. So you are trying to put together, and I do believe you, all of you are, something really positive, but it feels like it's in a vacuum. You're trying to keep steps. You haven't got enough people willing to work with you. And I mean, you know, Richard would expect me to say this, but we look at theme 1, working people, supporting people to live healthier lives. I have been talking with people at my local pool this morning who have got arthritis and they love SwimFit. Oh, but guess what? It's closing on Friday. So you are trying to do your best against a background that is working against you. And, you know, I am despairing as somebody who has been at the receiving end of brilliant care in the last few weeks. I can't complain about a health service, but I am desperately worried of someone who's 70 and in reasonable health about how anyone is going to afford anything in the future short of selling their houses. And I just think we need to be far more honest and loud and screaming at, you are trying to do the impossible because you haven't got a clear, you've got some vague guidelines and you keep getting, but it keeps forever being pushed back. And God knows what will happen after the next election. So, sorry, this is a rant from me. I'm good at those. And I don't want to put any of you down for all the hard work you're doing. But I know lots and lots of people are so worried at the moment. And just wanted to say that, really.
Thank you very much, Leslie. I'm sure people in social care feel very supported by knowing that, by us knowing that you're working really hard in a very difficult system when inequalities seem to be getting worse. Have we got other panels members with questions? Vivian, Alison?
No, thank you, Jackie.
No, thank you.
No, it doesn't seem so. I think you've answered a lot about the CQC. Thank you very much for that. And I think we're happy to bring the discussion to an end. Is Jill? Oh, no. So thank you very much, Richard. Thank you very much, Alexia.
Thank you.
Okay, all right. We'll look forward to coming back with more detail at another stage, but I'll take us on now to the next presentation. And who's presenting this one? Is it yourself? Yeah, okay. So that's lovely. Right. Would you mind introducing your panel as well as yourself?
Absolutely, thank you.
Thank you.
So thank you for the invitation to come along this afternoon and talk to you about joined up care in Kirklees neighbourhoods. I'm Catherine Wormstone, I'm Director of Primary Care at the Integrated Care Board in Kirklees. So we've got a number of people supporting this item this afternoon, as you would imagine when we're talking about neighbourhoods. So we've got Richard Parry, who you've just heard from, Strategic Director for Adults and Health at Kirklees Council. We've got Jill Greenfield, Service Director, Communities and Access Services from the Council. Jane Close, Chief Operating Officer from Lucala. Helen Duke, Assistant Director of Operations from Lucala. Ruth Buchan, Chief Executive Officer from Community Pharmacy West Yorkshire. We have apologies from Vicky Dutchburn this afternoon, but deputising for her on screen, we've got Jen Love, who's Programme Manager for Community Mental Health Transformation. Andrew Singleton, Service Planning and Development Manager from LCD, also supported by Helen Duke. And we have apologies from Catherine Riley and Amanda Evans. I'll just double check I've not missed anybody. I've got the whole cast there, so thank you. So if that's okay, shall I move on with the slides?
Yes, please do.
So I think for the brief this afternoon, you've asked us to give an overview of the new statutory arrangements that are in place as a result of the new Health and Care Act. So some of that will be focusing on the work of PCNs, neighbourhoods, and some of the themes that are coming out of the fuller stock take. And then a focus on the capacity of out-of-hospital care to include all aspects of community care, including adult social care, community services capacity, and primary care support. So I'll just move the slides on. Thank you. So by definition, the capacity of out-of-hospital care includes a wide range of partners, as we've just said, and they're all here represented today to support the sharing of information. And I think, as you've done with previous panels, ahead of the meeting, we've shared the data and intelligence pack covering the key bullet points that were in the briefing. So today's presentation will assume the pack has been read and we'll draw out key themes, so we won't go through the multitude of slides that were in the pack. And hopefully we can sort of embellish some of that with some patient stories and experiences and also allow time for questions. So moving on to the recap of the Health and Care Act. So statutory changes took effect from the 1st of July, which saw the formal creation of the West Yorkshire Integrated Care Board. The role of the ICB is to join up health and care services, improve people's health and well-being and reduce health inequalities. So we're made up of 5 places in West Yorkshire, of which Kirklees is one. And the development of neighbourhoods is central to the strategy of the ICB, but was further reinforced with the publication of the fuller stocktake in May 2022. So this is not legislation, but is very much setting the direction of travel for us and probably reinforcing the direction of travel that we were already on. So page 19 of the paper pack showed a graphic of the vision for embedding integrated primary care with building blocks of neighbourhoods of populations between 30 and 50,000 which deliver integrated primary care via multidisciplinary neighbourhood teams. So in Kirklees, I think we've been on this journey for some time, and the national and local focus has re-emphasised that direction. So the slides that we've got on screen just give a brief summary of the fuller stocktake. And many of these themes then we'll sort of delve into in a little bit more detail today. But I think some of the key ones that we want to draw out here are about building integrated teams in every neighbourhood, personalised care for the people who need it most, working with people and communities, the role of primary care and neighbourhoods in improving healthy life expectancy and tackling those health inequalities that we've just referred to, and some of the challenges that we share around provision of workforce, estates and digital developments. So as Director of Primary Care, my focus is on the 9 primary care networks that were registered in Kirklees back in 2019. It feels like a lot's happened since then. And I'll just move on to some of these themes here. So each of the primary care networks has got an aligned model of community service provision. And I think this is something that we were working hard to achieve before all of the guidance came into play. And each of the PCNs has got voluntary sector involvement and joined up support for care homes, which was very much accelerated during COVID. The pandemic saw many of the national specifications for the PCNs pause or delay. So whilst that could have set back the development of the PCNs, actually the close working relationships that were formed outside of the traditional organisational boundaries were formed during this time. And I think it was very much a case of everybody working well together to both respond to the pandemic and then the vaccination efforts. They range in focus depending on the populations they serve and the health needs and the ambitions of the PCNs. And we've recently updated a series of PCN data packs to support those neighbourhood discussions and a population health management approach. So the West Yorkshire ICB ambition is very much to accelerate the development of neighbourhood teams supporting our PCN, so far beyond the original ambition of the scope of PCNs when they were formed. So those integrated neighbourhood teams will use a population health management approach to proactively tackle health inequalities. But I think I must emphasise what PCNs are not. They're not formal organisations with a huge infrastructure sat behind them. They're groups of general practices that started working together. And often, you know, they don't have large teams of administrators or sort of managers, but most have got a PCN manager in post now. I think when the first West Yorkshire ICB board met, and when they met in November, they did a deep dive into primary care networks and some of the themes that were coming out from the fuller report. And I think some of the themes that it picked out on the slide are really pertinent to the discussion that we're having today. So it talks very much about the role of community pharmacy to help alleviate some of the demands. It also looks at good examples of integration where we're working well with partners, recognises the limitations that we have some places around primary care estate. So as we're rapidly expanding the workforce, we need to find places to house these people. We do have sort of acknowledgement that the patient experience is sometimes variable. So we work with Healthwatch and we look at the feedback and the patient surveys to know where that we need to focus our efforts. And obviously the PCNs pay close attention to that as well. And the public understanding of the model of delivery, I think, is really sort of keeping up with the different way that primary care is now engaging with patients. So we saw the rapid acceleration of digital ways of engaging with general practice in the pandemic, but that is sort of continuing, and also for patients to really understand the broad range of roles now that there are in operation in primary care. So we do recognise that sometimes the DES itself, so the guidance, can be a little bit inflexible, and we're really wanting to strengthen that neighbourhood approach as outlined in the fuller report. So I think at that point I'll hand over to, I think it's you, James, isn't it, next?
Cheers. Okay, so the role that I've got in Lacala is Chief Operating Officer, but I also hold a Senior Clinical Advisor role at West Yorkshire ICB, and it's in the context of delivering the community neighbourhood model that I'm talking today, and obviously all of that's in the pack. So whilst I do it for West Yorkshire, we do it for Kirklees. So in terms of that neighbourhood model, it is about making sure that we draw all of the capacity together, because it isn't about a GP, a district nurse and a social worker. It goes far, far greater in terms of what we need to do to deliver the increased demand that we've got on our services, and also about behaviour and culture of how we work together as a group of providers. And I think that really has paid dividends through COVID, and we have continued that working together. So for instance, whilst this work is very much about Kirklees, it also has representation from Calderdale and Wakefield, because if we work backwards from an acute trust point of view, the pathways, it's incredibly helpful to have the pathways the same in and out of the hospital. From a point of view of all sorts of providers understanding the services that sit in community, and particularly to build a model that absolutely supports people that can stay well at home, that really don't need to go into hospital, but with a real focus on using population health management data to actually drive the services and the different models of care that we're looking at. But really what our ambition is to enable a shift to more proactive care and much more about preventative models of care than the kind of the urgent demand that we see at this moment in time. And part of that is a big push for us to integrate our urgent care offer, and so that we have all of the services in community working together to really provide services when they're required. We talk a lot about something called the Canterbury Health System, and this is an idea that's spun out of mid-Yorkshire, but the Canterbury Health System originated in New Zealand, and essentially in its very simplest form, it's about making sure that we've got all parts of community capacity joined up, lined up with enablers to wrap around people and wrap around their care and support at home. The absolute ambition, like I say, to make sure that we keep people well at home. We have, like everybody else, got enablers around digital platforms and use of digital technology, because we need to do things very differently, and some interesting challenges around how in this new framework that Catherine's just described, how we actually work much more as an alliance model of care as groups of providers and less about commissioning and contracts. So what we've done in terms of progress to date, we started the work back in May across CKW with a focus on what a community neighbourhood model would look like in its wider sense, and we deliberately started with the unplanned and urgent activity because we knew that winter was just around the corner. So we spent a lot of time focusing on admission avoidance, doing the pieces of work to support discharge in a timely manner, and the new virtual ward that went live in October. And we created a detailed action plan. There's a number of work streams in that, and it is a 5-year ambition. We won't be doing this by next summer. And then in December, last week, actually, we had a further workshop that involved a wider group of people and partners, because we're building it up. And what we did was we focused on proactive elements of support. And actually, what can we do to build capacity in community, utilising and harnessing the power of everybody in the community to move it from a health and social care model to a true community neighbourhood model, and support particularly those people that are vulnerable and have got complex needs at risk of admission.
Sorry, can I just interrupt 1 minute? We're just struggling to find these presentations.
So there's 2 packs. So that's, I think probably the one that you're looking at is a much bigger pack than the pack. Did you send it through this morning, Catherine? So that presentation is effectively, it's the key themes out of that big pack that you've got.
Oh, okay. Sorry.
No, I think we said that this is a summarised
version.
Of the data and intelligence pack that we sent through.
Great.
Hi, I'm Ruth from Community Pharmacy West Yorkshire, and I understand you wanted to kind of have you had a question around how community pharmacy can help alleviate demand in hospitals. So I'm going to go through, community pharmacy as part of the NHS, our support for primary care access, prevention and early detection, and also supporting people at discharge. So first of all, there's 101 community pharmacies in Kirklees, so you've got a huge asset out there, huge NHS asset. And I want to outline some of what we're doing already as part of our core stuff. So this data comes from some information that was collated nationally at the beginning of this year. So we know that pharmacies provide, already provide an existing number of consultations per day, so it's 19 per average pharmacy. And if we look at where patients would have gone if they didn't have community pharmacy, we know that each community pharmacy essentially provides 95 GP appointments every week. So if we weren't there, that would be a much bigger issue for general practice access. We also know that quite a number of people we see, if we weren't there, would go to an A&E department, so that's about 7 for an average pharmacy per week. So we can really see there's an increasing reliance on community pharmacy as part of that first protocol, and part of that NHS service to help people with health and their well-being. So yeah, we've really seen that vast increase, and I think that's because during COVID, people really started to much better understand the community pharmacy and what we can do to help support them, which is really welcomed, and we're keen to do quite a lot more, but it does need to be funded and put into our nationally determined contract. So if I think about primary care access, and I'm really clear, primary care doesn't just mean general practice. Primary care is a much wider term. It includes community pharmacy, optom and dental. So we've got a community pharmacy service called the Community Pharmacist Consultation Service, and the aim of this service is to improve access for our population. It does require a referral from GP practice. If people can't walk in and access the service, we would like them to, but that's not nationally allowed. We are championing for that. Referral numbers are quite low, but there's a West Yorkshire meeting that's got multi-sector, and we are looking at how we can increase and steadily grow the use of the community pharmacist consultation service. We know that our current average is about 1 a week across West Yorkshire per pharmacy, and actually we know we could get up to 50 a week. So there's actually a lot of, I think, untapped potential there, and that is what we are looking at to help go from where we are currently to get to where we actually want to be and where the NHS ambition is for this service. The service really helps us in community pharmacy see people who are best seen by community pharmacy and help support them in that journey. So that, there is another element of this service. So we have 111 referrals. That's actually been going on for years, including people who access 111 online. They will also be transferred to community pharmacy for their care. Next year, we know nationally there's going to be a change which we can start to include referrals from urgent treatment centres. So again, community pharmacy is really starting to build up quite a formal transfer of care from other parts of primary care into community pharmacy where that's appropriate for the person. The feedback from this, from people that use it, the patients, is really high. It's very well accepted because, you know, there's a process to make sure that only the right people get referred on to us. If we think about prevention, we all know that, you know, if we can prevent somebody having, you know, we can identify that hypertension early, for example, and prevent a stroke, that really does help improve not only that individual's, you know, own life experience, but actually that has an impact on urgent care, A&E, and other health and care services. So community pharmacy has, again, it's a national service, it's the NHS Hypertension Case Finding Service. And this is really to enable us to help identify people with hypertension who are walking around now in Kirklees who have no idea they have hypertension. Quite a new service, but we are growing month on month. We are seeing more and more people being offered a one-off check of their blood pressure. If that blood pressure looks like it may be high, we are undertaking ambulatory, which is the second step of the process. And if that does identify somebody has high blood pressure, then we then refer to the general practice for ongoing management. So as I say, the last figures I have, because it takes a while for figures to come through the system, are for Q1 of this year. And we know that on average, there's about 23 people are having an ambulatory check, and there's about 435 people roughly every month in Kirklees that are getting a blood pressure check who hadn't had one previously or hadn't had one recently. And the last element I wanted to discuss, and this I think linking back to your question around how can community pharmacy help to alleviate demand in hospitals, I think there's quite a direct link with this. It's the discharge medicine service. This is a service where on discharge, if the hospital choose to do so, they can refer the details of the discharge medicines to the community pharmacy, which enables us to contact that patient, check that their medicine has actually, when they get their first prescription back from the doctor, has been amended and changed, and help support them in their first few weeks back at home with their medicines. This service is really powerful. We know that for every 10 discharge medicine service that we do in community pharmacy, we prevent one readmission. That's quite a high number. You know, it's quite a good rate of people that we can actually prevent readmission. And actually, if they are readmitted, they tend to stay in hospital for a shorter length of stay. So again, this does require somebody else to make that referral, and referrals are currently relatively low, but they are increasing, and we are in West Yorkshire working really hard to try and increase the level of referrals from hospitals to community pharmacy for this support for individual patients. It has gone in as a sequin, which is one of the measures for the hospitals, so we are quite hopeful we are going to see, and we are seeing increases, but we'll continue to work to maximise the number of people in Kirklees and across West Yorkshire who do get the possibility of having a discharge medicine service. So in summary, community pharmacy do see ourselves as part of that solution. We are keen to do more. We do see that shift now of community pharmacy doing more clinical services. We've got a contraception service coming next year. So I think we will start to see a better use of that asset, and we're working really hard together in an integrated way to make sure that we can maximise the opportunities we have. So now across to who's... Thank you.
Good afternoon, everyone. Can you hear me okay?
Go ahead, Jen, when you're ready.
Thank you. Firstly, apologise for not being there in person. I'm actually
Apologies, we're struggling, we can't hear you.
I think it's because I'm not very well, so can you hear me okay?
Yes, thank you.
Okay, sorry. I'll try and speak up. Apologies.
We're being asked if you've got your headset plugged in or something like that. We can hear some sound, but it's not enough.
Would you like to come back to me and I'll sort a headset out?
Can I just say, I'm sorry, but I am struggling a bit, given that what we've got has been very different from the summary that they've seen. And I think all of us are struggling a bit to keep up with everything.
Yeah, it's something that we'll need to address at the end of this. I think.
Can I, for my slides, there is a difference, and that's because I was asked to do my slides 2 days before I went on annual leave and was unable to provide a very brief summary of slides that I already had. I then answered the question that you asked us when I came back from leave. So that's why yours are different, because they had to be submitted for the first set before, and then I was away on holiday. So I've had to, it's just fallen really badly. So that's my, that's because of my circumstances to why mine are quite different. So apologies for that.
Okay, thank you, Ruth. Let's see if we can sort out Jen and finish the presentation, and then we'll move on. We'll just have to accept what we've got.
Good afternoon. Can you hear me any better now? No.
Jen, can you?
Can you hear me at all? Oh, no.
Apologies, we're still not hearing you.
But I'm not present at the meeting, but I'm attending it virtually, so.
And I can also hear.
Would you like to come back to me at the end and I'll see if I can sort some noise out, some sound?
Apologies, Jen, we can't hear you. Alison, when you spoke, we couldn't hear you either, I don't think. Just speak again.
Hello, everybody, can you hear me? No.
Just be patient. Unfortunately, we think the issue's at our end.
Is it worth skipping this and then coming back to it?
No, let's finish. And then just give it 2 minutes. Jen, I think you can't hear us because we're not speaking, so we're just waiting until we've resolved the technical issue.
Okay, thank you.
Alison, can you hear us as normal?
Yes, thank you. I can't hear you now, though.
Okay, let's move through to adult social care while we try and sort the issue out, and then if you can hear us, Alison and Vivian, we'll do that, and hopefully Jen will be able to get you to present in a few minutes. Who's presenting from adult social care? Is that you, Jill?
I think the next one is the personalised care services. In the pack, Richard will be doing the adult social care.
Oh, fine. So let me talk then briefly around kind of adult social care. So when we talk about adult social, or a lot of the conversation about adult social care is around the interface with hospitals and around hospital discharge. But of course, the reality is that the vast majority of adult social care is about supporting people to live as well as possible in their own homes. And so social care is naturally part of this kind of neighbourhood model. It's where good social care is based. We've got a set of, we moved to a set of neighbourhood teams a few years ago. They align with the teams in Locala. They've increasingly, as we've developed the primary care networks, networked around those. We've obviously, like every local authority, got some pressures in terms of kind of recruitment and retention and securing sufficient kind of workforce. We're working closely with the University of Huddersfield around that. But unlike a number of other local authorities, we've been much more successful in our ability to secure domiciliary care, so home care packages that go into people's own homes and provide that day-to-day care as part of a neighbourhood team with a very small local waiting list. We've invested in a care association, and one of the things that the care association is helping us think through is actually how do care providers become part of those neighbourhood teams. Certainly, when I'm talking to the primary care networks, they're very keen to make sure that that broad domiciliary care offer is seen as part of the solution, and that we are increasingly in conversations about what are the tasks that NHS organisations need to do, what are the tasks that actually domiciliary care organisations could pick up. So it talks there about some of the things like reablement. Early warning, and particularly with our and we've been working increasingly with domiciliary care colleagues around what does a digital offer look like. So we talked earlier about some of the digital solutions that exist. We know a digital solution won't work for everybody, but actually digital solutions in terms of things like case records, in terms of things like assistive technology work really well for a significant number of people. And so broadly, to kind of summarise, the next slide's just got the figures on that I've talked about, and I can't persuade it to come up. Social care is very much part of that neighbourhood model. It's part of that kind of multi-agency team. And as we've increasingly worked with the Care Association, we're able to build care providers very directly into that. So it's not just the things that the local authority does, it's things that the independent sector, domiciliary care providers, home care providers, and so on do to support us. So I wonder if the next slide in your sequence is around personalised care. I should pass over to Jill.
Good luck, Jill. Thank you. So I'll just very briefly talk to you about the work that we've been doing around personalised care, which really supports all of the work in practice that has already been talked about. It's really about building that relationship between people, professionals, and the wider system. It really means that people have choice, they really focus on what matters to them, and they have that control over how and the way that their care is planned and delivered. It's really based, as I've said, on what really matters to me, and it takes that broader, holistic approach and those non-clinical, and makes clear how we connect to communities around those non-clinical issues that sit behind often presenting clinical issues for patients. It is strengths-based and really focused on those needs. And like I say, it really has been working alongside the PCNs to develop a number of roles that have really been able to bring this to fruition. So just to really quickly talk through, we do have a number of roles that we've worked with colleagues really collaboratively with to develop, from our social prescribing to care coordination and our health and wellbeing coaches.
And these roles really provide that bridge from formal services to community. There is one step in communities and one step in formal services, and have been able to support a lot of our partners' initiatives around out-of-hospital discharge, responding to those pressures, working with Lacala on that urgent and integrated out-of-hospital support, a lot of our anticipatory care, and we are really now starting to see the benefit really realised of actually that joined-up approach and really working alongside. Sometimes it's been really great when we've been able to coordinate when a healthcare professional and maybe a social prescriber or a community plus worker has been able to go along to the same appointment, to coincide those appointments, to make sure that those social needs and non-clinical needs are considered as importantly alongside some of those health needs. There's some just example of the pilot that we did last year. We're still involved with our partners on a number of out-of-hospital support, and we're working closely with our teams at the moment around developing another pilot. And I think we now have, from the engagement that we have, a proven model that actually when we can work alongside our partners and that demand, we can actually make sure that those things about keeping people out of hospital or getting them out of hospital and the barriers and challenges in the social sphere, that we can overcome them quite quickly and make sure that people are more settled at home more quickly, or indeed are prevented from readmissions because some of that social support isn't in place when they've already been discharged from hospital. And again, I think the important thing is that we are really focusing on that holistic approach, the whole person, and really connecting across all of our services and systems. There is a couple of, couple of case studies there. Oh dear, I was winning and now I'm not, so I'll stop pressing the buttons. There are a couple of case studies, and if they're not in colleagues' packs, I will make sure that I'll send those on, because we do have a number of patient stories that we can talk to that really focuses on those outcomes. And I think from mental health prescribing, social activity prescribing, to some of our focused work around hospital discharge or anticipatory care, I think the real common theme is that it has enabled and provided confidence and connection for people to be able to self-manage, take the steps that they've needed to take, and feel more in control of the health and care that they have needed. I'll pass that on to colleagues.
I think actually we may be able to hear Jen, so I don't know whether you want to... Jen, are you still available to present your part? Excellent, we can hear you. We can, in fact, you're very loud.
I am very loud in general. Thank you for having me, and apologies for not being there in person. It's not that I don't want to be, but I'm not very well, so my voice is actually going a little bit and I am coughing a lot, so apologies in advance. Can you hear me still okay? Yeah.
Yes, please go ahead.
Okay, thank you. So, good afternoon, I'm Jen Love, and I'm responsible for the Primary Care and Community Mental Health Transformation Programme in Kirklees. Voice is already going, apologies. My work is dedicated to moving mental health services into the community to build capacity in primary care so that people can receive treatment for serious mental illness and lower levels of mental illness closer to home. And Jill's just touched on one of my roles being the mental health social prescribers. So each primary care network will have a range of new roles within a mini mental health hub. Initially, we identified 4 pilot PCN sites to work with. However, we've brought forward recruitment and we aim to populate all roles by year 3, which is next year. You'll see from your information pack a full update on progress with recruitment, although I do believe you've got some issues around those slides, so I'll happily share them after. We're currently focused on very operational aspects of embedding the new roles into PCNs, and we've regular task and finish groups with a range of stakeholders. Excuse me, a wider steering group and a regular monthly update to the Mental Health Alliance. We need to develop communications for our partners and patients, which I am leading on for West Yorkshire, and I look to the help of Health Watch to engage with service users to get the language that we use right. So sorry about my voice. A formal outcome evaluation will take place on a West Yorkshire and place-based level over the next 2 years to ensure the new roles and ways of working are successful and provide the right level of care. Bradford has been asked to design a health inequalities framework for West Yorkshire, and I'll be engaging with our key stakeholders to bring that to life for Kirklees. We've had a few challenges along the way so far. One being recruitment to our additional roles reimbursement scheme, mental health practitioner. That's quite a mouthful. And that is widespread across West Yorkshire. It's just workforce capacity and availability. But we are advertising again. And we have 2 PCNs who currently do not have their advanced clinical practitioners in post, just down to the fact that primary care have got real capacity issues around the physical health aspect of the training. Excuse me. Success so far is we've received really positive feedback from the roles already in place from patients and primary care colleagues, particularly around the mental health social prescribers and the advanced clinical practitioners. The pharmacist team's been recruited to and will commence work in January 23. This team will really empower patients to make an informed decision on their care plans, and further information is within the slide pack circulated prior to the meeting. So what does it mean to the person? What does it mean to you? So it means that you'll have a one-door entry into primary care with professionals wrapping around you if you have a mental health illness, be it low level or serious mental illness. And the mini hub will allow for a seamless transition to other services, including referrals into secondary care services when required. And from our feedback, we always hear from patients that they feel like they're being passed from pillar to post. And the aim of the transformation model is to prevent that from happening and allow GPs and other clinicians to really focus on their areas of expertise. So I know that's a really whistle-stop tour of the programme, and I appreciate you might well not have seen the information that I shared previously. Do you have any questions, or would you like me to talk through the roles, or over to you?
If you bear with us, Jen, what we'll do is I think we'll just... is there anything to sum up at all, Catherine? Are we done? All right. We'll just finish this presentation and then we'll go to Stacey and we'll come back with questions all in one go. All right, okay, so bear with us.
Thank you very much.
Thank you. So Urgent Community Response is a new service that we've had in Kirklees since November 2020. We were one of the 7 national accelerator sites selected by NHS England. We've got 4 main providers that are providing the service. Local Care Direct, we provide the triage from our contact centre in Huddersfield. We've got Curo, GP Federation from North Kirklees, and Locala, who provide face-to-face health visits, and we work with Kirklees Local Authority as well, who provide social care input into the service. What we are focused on doing is providing crisis response for people into the community within 2 hours, with the aim of preventing people from having to attend hospital. That was probably the main national driver for all areas having to set up urgent community response services. One of the main areas of focus for us is working with Yorkshire Ambulance, both with their 999 services and 111. There are a lot of patients in the 999 queues who have urgent care conditions that we think are suitable to be accommodated within the UCR. We recognise that the ambulance service work all across Yorkshire. They're not just purely based in Dewsbury or Huddersfield. They get about, and some of the community pathways that we have can be complex to navigate, so we're working with them to provide the simplest route into these services. So at the moment, across Calderdale, Kirklees and Wakefield, they can refer into our contact centre. We think by even small numbers will help free up an ambulance to respond to that heart attack or that stroke, which could otherwise be engaged if an ambulance is a lower acuity patient that we could be seeing. And again, with 111, we're working with them to increase demand, because if they can come to us, that will be a better outcome for the patients. We continue to develop our workforce model using different staff disciplines to expand the team and in response to some of the workforce challenges that the NHS is experiencing. And we're continuing to integrate with different services, so referrers, patients get a better experience, and we make more efficient use of the services that and resource that we have available. We've recently had a successful integration with the Locala short-term assessment response team. Have I got that right? I always forget the acronym. And with future plans to integrate with 2-hour district nursing referrals, local authority night sitting service. So any urgent response that needs in Kirklees that's outside of hospital from a community social care perspective can come via the urgent community response service in the future. And there is a few comments from patients that have used the service. And that's it from me. Thank you.
Thank you. So I think just the last slide, I think you'd asked a question around community diagnostic centres. So apologies on behalf of Catherine who sent this slide in, but I think that's just to note. So we've got approval for 2 community diagnostic centres, one based in Huddersfield and one in Wakefield at the moment. So these are being led out by the Trust, but obviously working collaboratively with the wider system. So they're in discussion about the exact location of the Huddersfield CDC, and we're working with the university to explore the opportunity of looking at that on the town centre premises, which I think is potentially really exciting, looking at some of the plans that are being talked about. Don't currently have a date for the opening of the diagnostic centres, but we'll keep Scrutiny brief, so I think there's probably plans to come back for a further panel at a later date. But the centres will offer a range of different diagnostic procedures, and obviously working closely with both the Trust and Primary Care to work out what the impact of those will be, but hopefully all additional activity. So apologies, I think we've reached the end, and apologies if you've struggled to follow. I think we thought we were following a similar format to previous ones, and I think if we'd gone through the number of slides that you've got in your packs before you, we might have been here until late this afternoon. So we did try to summarise, and again, if there'd been some differences, apologies for that. And I think just by the definition of talking about neighbourhoods, it encompasses such a wide range of initiatives and services, but hopefully what we've given you this afternoon is a flavour of some of those, and I think we're probably happy collectively to take questions. Thank you.
Thank you very much. Thank you for presenting. Yeah, we've a bit of confusion about the packs and also the technology, so well done you for getting through it. I'd just like to ask Stacey, if she's still with us, to just give us some of her comments as well, and then we've got all the information and we'll go to questions from the panel then. Stacey.
Mine's a question, if that's okay. So just in terms of the initiatives that we've heard about and we've seen in the pack, which sound great, how do patients know about them? Obviously, a lot of work has been done around different parts of the NHS and social care system. Is there a collective comms pack that's going to go out to inform patients from everybody? It feels like we have, so I'll give an example of a primary care network. It feels like we've got multidisciplinary teams within primary care networks now, and patients are still calling to speak to GPs. And if they don't speak to a GP and they are spoken to by somebody else, for example, or seen by somebody else, are they disappointed because their original person was to see the GP? You know, are we explaining that actually it might be best place for people to be seen by mental health practitioners or pharmacists? Or how are we explaining this to patients? Because actually nobody teaches you how to use primary care. You try and navigate that yourself. Are we collectively communicating that you might not see a GP, but you might speak to a pharmacist who's best placed? How are we sending that message to patients, and if anything that Healthwatch can do to help, we obviously will.
Thank you, Stacey. Catherine, do you want to pick up?
Yeah, thank you, Stacey. I think it is one of the challenges that I alluded to in the first couple of slides, really. And I know our colleagues in Bradford have done a bit of a campaign recently just to try and explain the breadth of roles that are now appearing in general practice. So within the pack, I think I referenced there's at least 17 of the roles now in the additional role reimbursement scheme, you know, plus wider professionals and wider services. So I think that's where the role of sort of care coordinators, care navigators, the social prescribing link workers, all of those roles that we've talked about become really crucial in making sure that people get to the right professional at the right time. I think we work really closely with our partner organisations. So some of the newer initiatives, obviously, as we've talked about things like UCR and some of the work that we do around some of the newer roles, we have to spend time explaining those to patients so that they realise that it's just as good. You know, they don't just have to see a GP, but you know, some people do just want to see a GP, and we see some of that feedback coming through in our patient survey. So I think it's a collective effort really from all of us to be able to explain, you know, just how broad now the range of roles and the range of services that they can access through primary care. But certainly some of the comms campaigns that we're working on through winter is starting to describe some of those in a little bit more detail.
Thank you. Right, I'm going to open it up to panel members, and apologies if we ask you things that perhaps you've presented but we were still looking for in our packs. So I'll just make that apology before we start. Does anybody want to go first?
I'm quite happy to start. Do you want all the questions together, or I've got probably about 4, or do you want them separately?
Yeah, give 4 questions, and then you can disperse them. We'll answer those, and then we'll move on to the next councillor. All right.
Sorry.
Might be here a while.
And they are kind of based on the pack that I've got, so apologies if they don't seem relevant. One is more probably of an observation than a question, and I guess it's thinking, I know some of what you've said is very much a long-term plan, so potentially 5 years, and that's great because we know we've got to have some strategic kind of forward planning. But I'm just wondering, in terms of what's going on now with the crisis that we've got and the financial situation of adult social care and the NHS with the 17% vacancies factors that's referred to, in reality, and I don't want to kind of take the wind out of anybody's sails because, you know, I've been part of the NHS and know how fantastic it can be. In reality, does this feel very much a vision or an aspiration rather than practical document? Because I'd be interested in hear when is this going to be put into practice in reality? Because it feels very much like theory at the moment. And I guess for me, thinking about all the challenges, how likely is it, I guess, to come off? And thinking about just patient flow and hospital prevention, which is, I think, one of the first things in the triangle. Things like the discharge to assessment is, I know the government stopped that, and know that my understanding that it comes from local provision. Is that something that's going to carry on in the next financial year? You've already alluded to quite a lot of things like investment in case management. Is that investment going to be guaranteed, or is that something that is kind of, well, hopefully we'll get it, but we're not quite sure. So that's kind of the first question. The second question is with regard to community pharmacy. Do you want tell me? No. Tell me if you want me to go slower, because I'm quite passionate, as you can tell, about things like this. Community pharmacy, and a question for Ruth. Just about kind of the locally funded schemes and thinking about those schemes that might really help keep people away from the doctors as part of the front door. So I'm thinking about things like minor ailments that are in my pack, supplementary prescribing. I guess the things that would really help, I mean, they're all of value, but with winter pressures, what's the kind of spread in Kirklees with those? Are they in deprived areas? I don't know if they are. I might, you know, probably because they don't live in what look, you know, in what might be considered to be an area where they're necessarily needed. But I wouldn't know that potentially I could go to my pharmacy if I was struggling and needed something for a minor ailment. So things like that. And I guess the last question, so I've got down to 3, not 4. The last question is really, again, probably a little bit of an observation, but in terms of a whole system integration, you've talked about the urgent care response, and there's lots of different partners involved, and I know we're working towards integration. One of the enablers, you talk about government's data sharing. How do you kind of all talk to each other? Because in my experience, quite a lot of the issue is around, well, I don't know what medication they're on because that's provided by Lacala. I don't know what to prescribe. I don't know what the hospital said. Just the kind of GP to Lacala, to the acute trust, to pharmacy. And is there any work looking at that across integration? So those are my questions.
So I'll pick up the first part of the question first. I'm going to hand over to Helen for some of the operational things. So is it an ambition or is it real? It's real. So some of the work started now. So I'll give you some examples to bring it to life, I guess. So as part of this winter's planning, we started to look at what could we do that's different to what we would normally do as a system, because I think it's fair to say there's no point in keep going out and advertising to recruit nurses because there's not any out there. So we've started to look at what else we can do. So we've got some schemes running. One of them is harnessing the fire brigade. So the fire brigade are going to resurrect a piece of work that they did some time back to actually go to specific houses that we will target and do check visits and falls assessments for people if it's appropriate. That then will trigger a referral into therapy. Obviously, what I'm not going to do is kind of leave any service with somebody and know where to refer. We are looking at a piece of work to engage with the voluntary sector to actually, for a specific cohort of patients likely to be over the age of 65 and admitted as an emergency, if they go home without any care, so we call them the pathways. So if they go home on pathway 0 or 1, that actually they get a check follow-up visit the next day with a script that absolutely checks that that person's all right. And again, a referral, but not a referral to a GP, because clearly there's hundreds of other professionals now that we can refer into. So that work started. The thing about have we got all of the staff as a system? No. So again, we're building up a model that says, so if you take district nursing, because it's predicated a lot on community nursing, so what are the things that we can do that doesn't require a nurse? So we're doing a big piece of work around supporting people to self-care, for instance. We're doing a big piece of work with the care homes, with Kirklees Care Association, to actually look at supporting them to develop roles in residential care, for instance. So some of their senior carers really want to learn how to administer insulin to their residents. So it's kind of releasing capacity to allow us to kind of go further up the triangle, I guess is the easiest way to explain it. But there will be a multitude of roles, and that then builds into a longer term piece of work that says, how can we work with Kirklees College, how can we work with the university to harness a whole group of professionals? And the thing that I talk about all the time is I am pretty sure since the bursaries all went, that we probably miss a group of people in their mid-30s that would have trained ordinarily.
Absolutely.
So we're looking as a bigger system piece of work at ICB level at what could we do that's something really different to attract local residents into the workforce, but actually might actually see us supporting them through that training, because people will stay. If we support them, they'll stay. I accept it doesn't kind of sort today and tomorrow's problem out, but we have got absolute plans in place.
Thank you. That's quite reassuring, because it's about, for me, it's kind of what's happening right now as well as the longer term. Yeah.
Yeah, I think things around the discharge to assess and around UCR, we've got integrated ways of working, we've got shared access to systems, so we can, we've got teams working in hospitals who can access hospital systems, we input onto system 1, so GPs can look at that. We are looking at how we can improve discharge summaries so GPs can get that information more quickly. So if somebody's discharged from hospital, they might go and see a GP a couple of days later. We want to make sure that that's improved. Looking at how we work differently, we're looking at different skill mixes, so where we've got carers, can we provide some clinical support so they can do observations? We're looking at digital technology. There's a piece of equipment called Taito that we've got. You could have a GP or an advanced clinical practitioner where you feed information back, so we can support some of the care at home to use a different skill mix of individuals. We're looking at using, for example, podiatrists that are very skilled in lower leg wound care. So actually, if we can employ more podiatrists to offer that element of support, you've got your multi-skilled teams that can deal with a range of different care. Through the UCR, there's different providers, but we're an alliance, so we've tested out an alliance approach of how we work. We contract separately, but we deliver one service offer, and that helps with the sharing of information. That helps with transfers of care. So where you might have had 3 different assessments taking place, we're looking at trusted assessment models. So actually, assessment can be completed in hospital, you transfer care where it's reviewed and your care can continue, as opposed to a referral, reassessment, a new care plan. So again, that takes out a need of having a number of different individuals needing to provide that care to actually sharing some of the roles and responsibilities. And that's happening right now, and we're continually improving that as we go on.
Great, thank you. It's really interesting. Thanks.
Yeah, and discharge to assess funding, so we are looking at moving forward. We've just put the integrated transfer of care case together to look at how that can continue next year.
So hopefully that will continue.
Absolutely.
But you're not quite sure.
Because we're more efficient in our ways of working, because we've tested that. And because we are more efficient, it will help sustain us moving forward.
Thank you.
Yeah, so I'll pick up the community pharmacy element. So that's you asked a question around whether this is vision or whether it's happening now. So the things I discussed today are all happening now, but they are all nationally funded. So the money's there, it's guaranteed, it's part of an NHS contractual framework. So you particularly asked me about locally funded schemes.
Yeah.
So we do have some. So from, for example, supervision service, so people who are on substance use pathways will have their medicines supervised daily or how often they need to have it done. Emergency hormonal contraception is another one, being as that actually to buy probably for most people the most appropriate, it costs £34. We know it's a big barrier, so Locala actually commissioned community pharmacies to provide that. You particularly mentioned minor ailments. Now, it depends what you mean by a minor ailment service. So the community pharmacist consultation service is around access to advice and recommendations for treatment. Minor ailments, some people define them as actually giving people, making paracetamol available, for example, free of charge under the NHS. Is that what you're meaning?
Yeah.
Okay.
Yeah.
So the NHS has issued some national guidance probably about 3 years ago, making it very clear that they felt most people should be paying for those medicines themselves over the counter. Now, agree with it or not, that has been a policy which I know the medicines optimisation team across Kirklees have been supporting general practice and prescribers with trying to follow. I absolutely accept, and this is my personal push against it, that actually those that are on low incomes might find it really hard to pay for these medicines themselves over the counter, and I think that's where it falls down. There is actually in Kirklees a historic, and we're talking from when I think Huddersfield was several, wasn't even PCTs, minor ailment service, but it's just really a historic one on a very, very small footprint. It isn't something which is openly commissioned in other areas.
Okay.
Now, nationally, as a community pharmacy representative bodies, we are championing to have an increased minor ailments offer and a pharmacy first offer, and we've heard that from central government. What we haven't seen is anything then coming through nationally. So, all these things are additionality and do need funding, and I think that is one of the barriers, because it would need money, and we need to think about the guidance around supplying medicines and that push and drive that where people certainly can afford it, they should be buying their own treatments for minor illness. So We do have some locally commissioned services in Kirklees. There is a minor element one, but I think we can probably discard it because it's such a small kind of footprint. And it is something, and certainly as we work further going forward, so community pharmacy is going to be commissioned by the ICB going forward. So I think that's going to give a bit more ownership back into place.
Good.
And into West Yorkshire to kind of look at what do we need for our populations. I'm certainly, Catherine and I are picking up conversations about from primary care.
Good, because it seems a bit of a no-brainer, doesn't it? If people don't have the funds to buy medicine over the counter, then they'll go to the doctor.
Absolutely. And
well, they won't go to the doctor, they'll go to A&E because they can't get into the doctor.
Yeah.
So it's just, you know, it's...
Yeah, so what we'd look to do is not that everybody can get that medication free of charge,
Sure.
but actually those that need to have that support can access that support.
Yeah.
Do you want me to talk about community pharmacy and access to records? Because that was part of your question.
Well, I'm conscious of time, so... But,
I'll leave that alone.
I think Alison has a question anyway that's related to pharmacy, so I think it is Alison, isn't it? So do you want to fire with that?
Yes, thank you very much. I've just got a couple of questions. First of all, in relation to section 1, when you talk about the neighbourhood teams, how will that work? Will each neighbourhood team be attached to a GP practice? Because each PCN covers quite big areas. So I just wondered about that. My second question is in relation to community pharmacies. And it's kind of feeding into my overall concerns of sustainability of this plan. So greater reliance is being placed on community pharmacies, yet my understanding is that up and down the country, community pharmacies are having to close. I understand there are two issues. It's a lack of qualified pharmacists, and you can't have a pharmacy without having a qualified pharmacist on the premises. There's poor pay for staff, and they can find better jobs elsewhere. And then the other thing is that I understand that pharmacists are placing orders for drugs, paying for those drugs, and then the money that they receive from the NHS doesn't cover the cost of the drugs. So the pharmacists are having to pay for them themselves, and which obviously isn't economical in the long run. So I just have concerns about community pharmacies and the sustainability basically of this plan from various aspects. I just wonder if you could perhaps enlighten me or explain exactly what's happening. Thank you.
So do you want to pick the community pharmacy one up first, and then Catherine, will you direct the second one?
Alison, thank you very much for your concern. It's well placed. So I'll kind of cover off. Community pharmacy viability is a concern because we are paid under a global sum from the NHS nationally that was reduced 8 years ago and has remained flat. So essentially year on year we're having funding cuts, and it really is starting to tell. Pharmacy teams are having to reduce any unfunded services. They are reducing their team sizes, and as Alison pointed out, we have got closures as well because some are no longer viable. That is a real concern for us, and it's a real live issue. It's one which nationally we're negotiating to get an uplift in that global sum. So yeah, it is a concern, and my organisation support pharmacy. We're supporting where we can, but we can't magic up money. You're also right about the workforce issues because we mentioned the ARRS roles that are going to primary care networks. As a pharmacist myself, I absolutely see the value of pharmacists and pharmacy teams being in primary care networks, but the drive the government nationally have had to do that, there was not also an associated, let's get more people to qualify as pharmacists. So we are really struggling. That again is leading to opening issues because if we can't get a pharmacist to actually be there on the premises, we can't open it, and we know that is happening across West Yorkshire. So we're nationally we're championing that. There is no short-term answer to that, Alison. What I will say, though, is those services I mentioned, the hypertension, the discharge prevention service, and the community pharmacist consultation service, all are funded. This is part of why we want to increase, because not only are they good for our patients, but they improve community pharmacy viability in Kirklees. So we've got that fixed global sum. So actually they cost the NHS no more money, but the more of that activity we get in Kirklees, the more viable our Kirklees pharmacies are. So actually we've got that other incentive for pharmacies to provide more of these services, which is why we want more referrals from general practice and the hospital trust, because it will make our Kirklees pharmacies more viable. So as part of primary care, Catherine and the College across West Yorkshire and myself talk about the issues facing pharmacy. There is no short-term answer to that. It is something we have to have a national increase in funding. And as we have local impacts, we will discuss and try and manage it as best as we can. But essentially, we have got less pharmacies than we had, and I think we will end up with a smaller number.
Thank you very much. I mean, thank you very much, Ruth. It's a tragedy in the making. I really hope that you will remain viable and that you will get the referrals from the GP practices that you mentioned. Thank you.
Shall I pick up the first part of Alison's question, which I think, if I've understood that right, was about the alignment and attachment to either GP practice or PCN. So I think many of the challenges that Ruth has just described are very common at the moment across NHS services. So the challenges with workforce and also with premises. So I think when we talk about alignment, for me, that's in two senses. One is the building of the relationships between the practices and the other agencies to create those MDTs, and then there's the physical location of where do we actually physically put people, and I think often that's where certainly in some of the more typical general practices that we might have been working with over the years, they often don't have the space. So when we talk about alignment, well, I think it's very much for the resilience of the services and of general practice that we build in that network at a neighbourhood level and at a PCN level, rather than trying to divvy up all of these new roles into individual general practice, because some of those, particularly with smaller lists or with smaller buildings, would struggle to house another 17 people, for example. So I think that, it's part of building that sort of infrastructure at a network or a neighbourhood level. And I do think we've got quite a lot to do, both in terms of recruitment and then getting best use out of the space that we've got. So it might not be just thinking about typically these roles have to sit in a GP building. It might be that colleagues in Locala have got space in some of the buildings they use, or colleagues in local authority. So I think when we're thinking about estate, again, it's very much thinking about it as a collaborative effort to make the best use of the resource that we've got, rather than in the silos that we might have typically thought about things in the past.
Right, okay, that's good. Thank you very much for explaining that. Thank you.
Okay, it looks like Leslie, are you wanting to follow on from
that? Briefly, coming in on that point, and I might have raised this before, but we kind of had a perfect storm in terms of the village, Slough, about 18 months ago now. I was living there because my partner at the time was end-of-life meds and stuff. We had 3 chemists in the village. One was in the doctor's surgery. One was another company that was on the Manchester Road, and the one was the main, what we considered the main community one on the. Within the space of weeks, word was that Medicare bought out the one on Manchester Road, so he closed down. They closed the one on the main street, and to a huge outcry, and they moved it into the new Colne Valley, the mill, in a much, much smaller space. And it was bedlam for 8-9 months. It didn't matter how often I got into Medicare about it. So, it does feel that there's a need to nationally control. And when we went to the doctors about it, they said, we can't do anything because they've rented the space from us. And so we had people leaving that pharmacy, going to booths, coming into town. And it's just an example of something you're only too familiar with, that need for a sort of national register and brought into an overall control. So, yeah, great that you've got that passion and awareness about it.
Would you like me to respond to that? Yeah. So your pharmacy is under the NHS regulations are under control of, it's called market entry regulations. So any movement of a pharmacy from A to B within a town or any mergers have to kind of go through that regulation. So the one thing we can't regulate for is closures, because that's down to viability. So in order to remain open and providing a offer in Slough, I suspect what's happened, I don't know the business, but I suspect somebody's had to look at actually where can I save costs? How can I continue to provide services, but it might not be in such a big premises, it might be with not so many staff, and I may not be able to do non-funded NHS services. For example, delivery is not a funded service, so it's something pharmacies do as a business decision. So, I am really sad that you haven't got that access you used to have, because I suspect your opening hours might have reduced too. But the reality is that's what we've been driven to do through the fact that we've got to be viable, and the other option is just to close the business altogether, which would leave you then obviously with a much bigger access problem. So I think it's really it's the outcome of that 8 years of every year reduced funding, and that is unfortunately what we have seen across West Yorkshire in more than one place.
Thank you. Has anybody else on our panel got questions? Joe?
Thank you. I've got a couple of questions. Is on the community diagnosis centres. I'm getting the strong impression that that is going to be based at the university and their new healthcare facilities. Also, what was the rationale behind basing one in Wakefield so that people from Dewsbury and Batley would end up having to go either come to Huddersfield or go to Wakefield? And the other question that I had was regarding sort of the virtual ward. Is that going to be a facility to stop admissions? Or is it going to be to facilitate quicker sort of discharge back home to patients? And who is actually going to be overseeing that? Thank you.
Can I just add about the community diagnostics? Is it picking up new demand, or is it picking up demand that's been reallocated from hospitals? I'll just add that to that one while you're doing it.
Yeah, I think it probably is both, and I guess that, you know, I'm not the expert on this, and we've got sort of project managers now in post that are working with the scheme as a whole and also with partners. So I think, as far as I'm aware, the discussions are still ongoing, but I don't know whether, Jane, you're any closer to some of the detail.
I wouldn't be surprised if it ends up at the university. I think they are the major discussions, but I think it's probably fair to say that the two big centres are Huddersfield and Wakefield, but there's going to be a number of smaller hubs as well in the plan. So I would hope that it would negate the need for people from Dewsbury, etc., to be travelling over. But again, we can probably get you that level of detail from Catherine to answer that specific question afterwards. Between us, we'll pick up virtual ward. Well, I'll let you, Helen.
Yeah, so for virtual ward, we're doing it in 2 phases. So it's new within Kirklees, and we're doing it as a Kirklees, Calderdale and Wakefield approach, because our 2 acute trusts oversee the services. So what we've done as part of phase 1 is to support people coming out on discharge on virtual ward. So they've had all the diagnostic assessments, they've had a level of stability, but they've still got that acute need, but we can transfer that into community. So we've done that to test out some of the pathways and processes. As phase 2 into the new year, we'll be looking at an admission avoidance route. So we'll be looking at doing that assessment and diagnostics in the community, be overseen by a consultant, will deliver the same level of care at community to avoid people going into hospital. So it's a 2-phased approach that we're looking at doing.
Vivian, I know you've commented around travel times and costs. Do you want to pick that up?
I have, Jackie, thank you. I noted with concern that the centres are Huddersfield and Wakefield at the moment, and appreciate that we're all together in a trust, but representing the people of the north of Kirklees, I'm really concerned that there isn't one, at least in Dewsbury. It's just adding travel time and travel costs when people are greatly struggling with the cost of living as it is, without making it harder to struggle to access other healthcare. And I know it says there is one plan for Dewsbury, but when?
Okay, it sounds like we'll need to get that detail from Catherine, but we'll check on that.
Thank you.
I think it's just drawing attention. I think in the slide pack, granted, we're not sure that we got entirely the same ones. However, it does say preparing a business case for 5 further smaller CDCs, as Jane's just mentioned, one of those in Dewsbury, locations in Calderdale and Wakefield. So it just specifically mentioned Dewsbury there.
Okay, thank you. That's reassuring. Oh, go, Joe.
Sorry, can I just clarify, when you actually say a smaller community diagnostic centre, that to me sort of reads that there'll be a limited range of actual services there. So obviously is, again, people of Dewsbury would be, if that is the case, people of Dewsbury, etc., would be disadvantaged. It would either be Wakefield or Huddersfield to access a full range of services.
Okay, shall we note that and make sure then that when we do pick up with Catherine Riley that we can answer that. Can I just ask a question about primary care networks and how really they are gelling now with a wider kind of social team and with certainly the councillors. I know the councillors have been invited to primary care network meetings. I'll be honest, the feedback that I've had has not been overly positive yet. It's been we've been invited to the beginning of a meeting and then asked to go because there's private business to take place. So I'm sure that's not where we're aiming to be. So perhaps you can just give us a little bit more idea about how we're actually widening that approach.
Absolutely. I think if I pick up some of this, I'm sure Richard might want to add to it as well, if I sort of pick it up from the primary care network. And I think if you go back to the principles of the fuller stocktake and the development of neighbourhoods, bringing together the primary care networks who have got a neighbourhood focus and the local elected members who've got that same focus still feels like the right thing to do. I think there's probably some things to work through around the mechanics of how that happens, whether the PCN meeting was the right place for that conversation, when the PCNs do have a big range of other business to do and obviously some of the service specifications that they're working on. So I think we're just thinking about evolving that process so that we manage that conversation and we build those relationships and try and still maintain that neighbourhood focus, maybe looking at some of the things and the themes that are coming out of the PCN data packs still feels like the right thing, but I think a little bit of learning and reflection, I think probably all round on maybe the best way for that to happen, but I don't know whether Richard wants to add.
Yes, I think if you go back pre-COVID, the emergence of the primary care networks, and we, at that time, I think saw them as being much more than just about general practice, about this being the opportunity to take that much broader neighbourhood model. What then happened was obviously we got into the pandemic, everyone's very focused on delivering against the pandemic, so some of those development conversations didn't take place. And what's more latterly happened, as people have described, is that primary care networks have been given quite a wide range of roles that they now need to employ. And so what we thought originally was going to be much more a partnership approach is almost making primary care networks into mini kind of provider organisations. And we've reflected on, therefore, rather than people trying to join the primary care network, what we probably need to do, as Catherine says, in terms of the fuller stocktake, is to almost there be some kind of neighbourhood meeting, which actually the primary care networks join as appropriate. You'd have potentially things like the schools as community hubs in there, your local VCSE organisations, the elected members who are the kind of primary care leads. And so seeing it, or rather than trying to invite oneself into the primary care network, actually create a neighbourhood model and invite the primary care network into that. And I think we kind of realised that, you know, in our eagerness to get going, we used a set of pre-existing meetings, which is the kind of business meetings. And it would be rather like if we were wanting to have local GPs come and talk to elected members. It's the equivalent probably of having invited them to come to a scrutiny meeting or a kind of a cabinet meeting or whatever, where actually there's an agenda, there's a level of business to be done. Yes, they have the opportunity to meet you in the margins, but it's probably not the... We did that because it was a date that was in the diary where we knew the right people were going to be in a room, rather than it was the right meeting to have that kind of conversation. So what we now know is that actually we need to do a lot of that outside those more formal business meetings, in the way that actually it would probably be helpful for GPs to come and sit in a scrutiny meeting from time to time to understand the process of scrutiny, or to go to cabinet to understand the process of cabinet. But actually if they want to build relationships and do business, they do that outside of those meetings in a different way. And so, you know, that's been our kind of reflection on the 6 months since we first established those roles, you know, because they've not been going long, and it's been at a time when there's been a lot of kind of pressure in the system. We also know that each of the 9 primary care networks is very different, and some have had long-standing relationships with a wide range of organisations. Others have been probably more internally focused on kind of delivery, and that shows again in terms of some of the ease with which people have been able to build those connections. And, you know, we've always talked about in Kirklees, there can't be a one-size-fits-all approach. And I think we need to step back now and work out for each of the 9 primary care networks and each of the 9 lead counsellors and indeed the other organisations that exist in each of those 9 places, what's the best approach, and it will be different in different places.
Okay, thanks, that's great. And I think for years we've been talking about GP attachment and place, so not necessarily aligning. So that's great. Can we just also ask something about the mental health team? If is Jen still there?
I am here.
Oh, yes. Brilliant, Jen. I think you've actually already covered this, but we were talking about the the mental health practitioners that you've got. You've got a little team in each of the primary care networks, and they will be in reach into GP practices. Is that the understanding? Have I got that right?
Right, yes. So each role is set up differently. So each PCN has, for example, a mental health social prescriber. Each PCN will have a advanced clinical practitioner. The blended pharmacist model there'll be roles that cover all 9 PCNs, and the physical health and wellness, they've just changed the name, so I'm just making sure I say it right. That team started working with 2 PCNs and expanding. So what we've done is worked with the willing and offered the services out. It's very much supportive to get our patients to have their physical health checks. We all know that patients with an SMI have 15 to 20 years knocked off their life because of their SMI and the medicines, etc. So it's vital to get those people in. So each role, as I said, is approaching PCNs differently. And the ACPs, for example, offer a mental health clinic 1 day a week and are in PCNs training on the physical health. And as I said, the pharmacists will be spread out across. So I'm happy to provide that detail if that answers your question.
Thank you, Jen. That's really helpful. Just as another level, we have been asked or tasked by the Calderdale and Huddersfield Scrutiny panel to have a look at what the actual capacity is out of hospital compared to and whether it can accommodate growth, basically. There's a data set that's gone in to Carol McKenna to help us understand that, but it would be really useful if we could get a feel of whether you feel you are just keeping up with current demand because of the workforce issues. I mean, we've talked, Richard, that 17% vacancies in some areas. You know, are we just keeping up with all the new initiatives? Are they just keeping up with demand, or actually do we genuinely feel that we are accommodating growth?
Do you want me to start? I think in some of the services, some of the bigger services, the demand is exponential. We're probably at this moment in time keeping up. The opportunities for growth need to come from different skill sets and different professional groupings. So, for instance, we know that Huddersfield Uni are well oversubscribed for their paramedic course. So it might be that we would look at bringing in some paramedics, but actually rotating them through primary care, UCR, the urgent response services, and kind of through the ambulance service. So it's not sorted now, I think it's fair to say, but we have got some plans that should go some way to meet the increased demand and the new services. Unfortunately, the new services that are coming out nationally require the same skill set of advanced clinical practitioners largely.
So at the moment we're robbing Peter to pay Paul.
Hence the work that I alluded to about the very different roles, yeah. And there is some benefit from our point of view in working alongside Calderdale and Wakefield Community Services to exactly stop robbing Peter to pay Paul.
Thank you, Jane. Do you want to add anything, Richard?
I think we've talked about, I mean, one of the things we've talked about often is workforce planning and understanding, what are the traditional roles that we'll need to extend for the new workforce roles. What's been really helpful as part of the West Yorkshire ICB arrangements is the new head of people is looking at workforce in its very roundest sense. So Kate Sims has been engaging with care associations across West Yorkshire to understand what's the need for in terms of supporting the social care workforce, the areas of kind of challenge. And so very much taking that kind of one system approach, because I think, again, there's sometimes been the risk in the past that one bit of the system solves its kind of workforce challenge by recruiting from another part of the system. And so that piece of work, looking at things in the round, will be really important. We obviously have a university on our doorstep, which is actually training the cohorts of staff. There's going to be a very big investment into that innovation campus. So there's something about us continually working with the university to take advantage of that. We are in a privileged position compared to some of the to some neighbouring places. So there's something about very much seeing both Kirklees College and Huddersfield University as part of that solution in terms of that future workforce supply. Making sure that we've got a really good offer locally, so that as people come out of college, as people graduate, they're working in our local system.
Can I just ask one last question? Thank you, Rich. Sorry. One last question around urgent care and the urgent care system. Really, are we picking up demand that used to be managed by primary care there, or do we genuinely feel that we're moving things away from hospital?
There's probably a little bit of everything in there. So undoubtedly, the majority of the referrals into the urgent community response are from general practice. Now, some of those referrals, they may have directed the patient to hospital. We can respond quickly and we deliver better patient outcomes if we can prevent that hospital stay. I think the reason why we're working with the ambulance service is that's the biggest opportunity to prevent those hospital admissions and attendances. So that will definitely prevent some of the pressure on the hospitals. It won't solve the world, but it might make it that little bit better.
And I'll just add to that. So because we had our urgent community response, which was kind of the ACP medical model, we had what referred to as a START, the short-term assessment response team, which is a multidisciplinary team of nurses, therapists, and then we had the local authority carers. Pulling that together into one hub, it's taken away confusion around which service we need to refer to. It's gone from 3 single points of contact into one, and that's with the intent to increase those referrals. People that come through primary care, you've got that one front door, and then bringing your district nurse element through the front door. Moving forward, again, it's bringing it all together. From a YAS perspective, we're doing a piece of work around West Yorkshire. So the 5 key areas, if we can make that more streamlined, it supports YAS to understand they have that one number. So from a CKW approach, we are having that one come through the LCD hub now. And again, it's taken away any confusion. If you work in Wakefield or Calderdale or Kirklees, wherever you go, there's that one number. So I think that's going to be more positive, and we will see an increase in referrals coming through UCR and avoiding that hospital admission.
Thank you. I was
Sorry,
going to check if there were any more questions. Here we go, Leslie.
It's just very quick, and there's a side from me which says, do we really need all nurses to do a degree? Can we not bring some qualification that suits those who want to be vocational? But I know that's for the future. Okay, so generally, as a counsellor in a ward, one of the things, and I'll be honest, that a lot of counsellors have struggled a bit with, and then I'm kind of getting the feel of why it happened. But this alignment that wards were then aligned with the PCNs has meant that some different wards who, councillors got used to work have had to rethink. And if you're not familiar with the PCNs and how they work, that's been, a bit of a difficulty. But one of the things I do feel strongly about, I can see the possibilities of what you're trying to do. And I think Slough, it's been really lucky that we had that centre open. And I wanted to end with something positive, because the link using the cafe, warm place, active walk beforehand, then they go on across to the drop-in centre. But the thing that's missing in all this, and I've raised it before, when it was all launched and the cabinet member came over and blah, 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 and we had 20-odd prescribers and with all the little badges and all, and the public were not there. And it's communication, and it's the thing I come back to more than anything else on the council, is there's a lot of brilliant stuff going on, but people aren't aware of it enough, you know, and I know maybe you've got limited publicity budgets, but we could almost do with town criers that go walking around, you know, come on, because there is this woman, Jackie, sitting in an office now in Slough, willing to listen to anyone's issues about help, but, you know, all these things need to be out there in a way that's just more friendly for the community. But I do think it's potentially a brilliant initiative if you can keep recruitment up. I'll end on that note.
Thank you. Well, I don't know how you did it. 4 o'clock. Well done. First of all, can I say thank you very much for presenting and for answering questions. As ever, I think we got so much more out of the question answering than trying to find where we were in the pack. So I think you've presented some good evidence about some integrated workings. That's really positive, and especially when services are under such pressure. Thank you for that. It is a huge agenda. I feel like we've barely touched the surface. So I'm sure as we develop, we'll come back and ask for more. So Richard's noted what we've already asked for in the thing, but yeah, thank you very, very much. Thank you. Really appreciate it. We'll just pause for 2 seconds, just until people have been able to sleep. But we've got the workforce plan, so don't us get up. Thank you very much, Jen.
Okay, thank you. Thanks, Jen.
Thank you. Oh, I forgot the Christmas. Vivian Allison, we're just going to have a look at the work programme now, if that's all right. We did talk in the pre-meet. I don't know, were you both available at pre-meet?
Yes.
About
Jackie were,
yeah. So we talked about maternity. So we'll just cover things that we've already done previously to start off. We talked about maternity, and really, at the moment, we've got basically a holding response around the birthing centres. So we have raised that, particularly with Calderdale and Huddersfield, because actually that birthing centre at Huddersfield now has been closed since March 2020. And we've been invited as a panel to go and look at the maternity services over at Calderdale. Now, I think we are probably going to accept that invitation to go and do that, but we are, at the discussion prior, we were still saying that the issue is that we need to have a timeline and a plan with regards to what's actually happening, particularly with that birthing centre. But I think Mid Yorks and Calderdale and Huddersfield were going to work together and perhaps come up with something that would meet the needs of Kirklees mums and parents, I should say, and children in the first instance, and then move to a Huddersfield-Dewsbury model. So we'll pick that up. Obviously, we did discuss dentistry, if you recall, and particularly around Low Carla. And I think we're going to schedule dentistry for March. It has been discussed now as to West Yorkshire level. It's a health scrutiny panel at West Yorkshire. And the responsibility for commissioning dental services transfers across the place-based integrated place-based system from April. So I think March is a good time. So I think we can schedule that. You've heard around, because I mentioned it in the meeting, around the review around looking at the capacity for Calderdale and Huddersfield and their business case, so trying to understand whether or not we have got sufficient capacity outside of hospital. So again, we'll share that pack of data with yourselves and discuss that. Probably at the next meeting, we should have it by then. So we'll discuss it at the next meeting outside of the agended items. So, anything else regarding the work plan?
Can I just raise something that's probably more for governors than here, but I just wanted to bring it up in case people didn't know this. I've recently spent a fair bit of time in hospitals, initially in Leeds, where I had my surgery and tumour removed, blah, blah, blah. And then because of problems, I ended up back in HRI. What is interesting is computers, systems, information. So I am still being covered by nurses from the team in Leeds, but they could not see anything about my admission because I was taken in by ambulance because everything went doolally. They didn't know anything about it. So, it's a bit of an issue. I mean, I know it's a long-standing issue, and there was always a long-standing aim that computers should records, but it feels to me that that's a big gap that needs questions answered. So if they do have different computing systems and a patient ends up between two, there has to be a way of that data being transferred fairly quickly, I would have thought. People like me are gobby, and I can tell them what's happened. But you know, not everyone can do that. Just mentioning it.
Okay, thanks, Leslie. We'll just go back to the work plan. No, I mean that Richard's noted it. That's what I mean. And the reality is, I think as we get to a West Yorkshire Integrated Care Board, probably from a West Yorkshire perspective, they'll get to that level. But no, I didn't mean shut up.
Sorry, the problem is each individual trust has their different patient electronic records. I know the one at Calderdale and Bradford is actually the same system, but I, as a Calderdale nurse, couldn't access my patients' records for, say, if they've been to ophthalmology at Bradford.
I think you're absolutely right, Joe. I think one of the good things that we heard was some of the integrated work that's been done between health and social care. They could actually see the records, so that was a positive from that. Anything that we want to raise with regards to the work programme? Right, Richard?
Yeah. I mean, it's just to help me really. We've got obviously January meetings now been the items for January now been agreed, so we will have the item covering palliative and end of life care, and that will be led by the chief executive of the hospice, Kirkwood Hospice. And then we'll have public health, haven't we, in relation to the inequalities in access to healthcare services. So Emily will be obviously leading on that one. I've now put for March dentistry down, and we'll obviously need to look more closely at scoping something out in terms of a brief, so we can do that. So it would be helpful maybe if there's a second item that you might want to consider for the March meeting.
I think Helen was in the pre-meeting talking about should we have a bit of a deeper dive into what's actually being provided from an adult social care perspective. Was that what you were suggesting?
Yeah, it was around community provision around domiciliary care. So yeah, I'd appreciate that. Yeah.
How do people feel about that? Yeah? Okay, so
yes.
I think...
Yeah.
Okay, so I think that's firmed our programme up for the year, and in January, can we just make note that we're going to review the out-of-hospital capacity? Yeah, okay.
We've also got the programme about revisiting COVID figures. Are we not going to bother with that then? Are we deciding that as a... You know, it was originally down, wasn't it, to look at COVID? Update. I don't know whether we need to do it.
I think we agreed to weave it into what was actually happening
Okay.
because it
Oh, that's
impacts on
fine.
workforce and on demand.
Yeah, I think we did.
So I think that's where we got to with that. That's why I looked a bit surprised when you said it. Perhaps we didn't share that with you, Leslie.
Yeah, I mean, we have got the impact of COVID on our work programme, and we've kind of tried to. It's almost like a bit of a golden thread in some respects, isn't it? But there is specific elements in there that we could potentially pick up, particularly around things like use of digital technology, new ways of working. But we have covered some of that anyway, haven't we, in some of the discussions we've already had and will be having.
We'll just go through that, Richard and I, and just make sure that we have covered it all off, but thanks for that reminder. Other than that, I think we're probably there, aren't we? Okay, so shall I call the meeting to a close and say thank you very much as ever to you as a panel. Brilliant.
Thank you. Thanks very much for the
Good questions, good questions.
Yeah, thanks Richard as well for organising. Really appreciate it. Thank you.
Thank you, Alison.
Thank you.